Once again, I'm Vince Bergella here from Jefferson in Philadelphia. So this second talk, we'll kind of follow up on the first talk, and we'll talk more about the techniques that can be done in a C-section to minimize the future risk of accreta, which I think, as I made the point before, it's where we're going to go. So what about different techniques at C-section to decrease the risk of accreta? And I go over four major categories, kind of when you do the C-section, does that affect the risk of cesarean scarectopic or placenta accreta spectrum? Where and how you do the uterine incision? What about what you do inside the uterus, once the baby is delivered, and then how you close the uterus? And I'll try to show you some data from randomized studies, retrospective study, but the truth is that once we began to look into this, and I know some of you have as well, there's actually quite a bit of literature, and we're actually doing now a systematic review with a resident and medical student here at Jefferson. We are not done yet because we actually found hundreds and hundreds of pertinent articles, but I will kind of weigh your appetite for the paper, hopefully later on this year, for what we're finding, or at least the issues that should be considered. For example, in terms of timing of cesarean delivery and future risk of placenta accreta, what about in labor versus before labor planned? I think there's conflicting data. Again, there's this nice review by Herbert last year that looked especially at the cesarean scarectopic risk. And it is possible, some data that maybe a cesarean before labor may put people at risk, but there seems to be also data that says that a C-section in the second stage, if you do a section in labor, that the worst time it's actually in the second stage. And in the second stage, the risk of a cesarean scar implantation and an ectopic is higher. And there are also a handful of papers saying that if it happens after rupture membrane, that may be a risk. All interesting data that I think needs to be verified still. In terms of opening the uterus, does that make a difference how we open it? For example, there is some data, I quoted a couple of studies there by Sangara and by Janfi, retrospective data, that a vertical incision causes more of a risk of an accreta in the next pregnancy. So, for example, avoiding a vertical incision that we try to do in general, it's important. Interesting, there is a randomized study in the ESWOG journal, in the White Journal, comparing putting the incision in the uterus kind of high or low, 2 centimeters above or below the placa, and in the 56 that got pregnant after they were randomized in the first C-section, in the next pregnancy, nobody in an accreta. So again, some of these studies are great and well done, but they're hard to do, and you need big numbers to really look at the risk of accreta, especially after just one C-section. I couldn't find, but I'm sure it's there. Again, our systematic review will bring up hopefully some data on what about if you make the uterine incision straight versus curved? What about its length? And then, we usually like to open it bluntly. Does that make a difference compared to sharp incision? It makes a difference then in terms of extensions, for example. Blunt has less extension, less blood loss, but we don't really know about future accreta risk. And same thing with, do we expand it horizontally, or there's some data that actually expanding it cephalocaudally ends up with less extensions on the side, if you can see my hands, but no data on these techniques in terms of future accreta risk. So once you're in the uterus, what about what happens while the uterus is open? Does it make a difference if you remove the placenta spontaneously, and there's some data that that's beneficial for blood loss and infection. But what about the future risk for accreta? I have seen C-sections in many continents, in many hospitals, and people scrape the uterus with gauze, sometimes with curette even. I've seen iodine poured in. Some people put antibiotics. Does that all make a difference? We don't know. Interestingly, there is some data that if you put some adhesion barriers, maybe yes, less niche formation. We're contacting some of these authors to see if they have more data, especially for a future pregnancy, because what we're most interested is the risk of accreta and not this other variables that may be associated with accreta, but not all the time, like niche and thickness, etc. I think that most of the data on this issue of how can you prevent a future placenta accreta by doing a good C-section to begin with, it's on uterine closure, and it probably makes sense that it will be on uterine closure. So we'll look at some data on the suture. Does that make a difference? I think the biggest controversy is do you include the decidua or not? Do you go full thickness or not on the uterus? I think there's some strong feelings, but still limited data. What about if you close the uterus continuously or interrupted? And if you close it continuously, what about locking and not locking? There's some data, for example, that if you lock the uterine closure, the risk of uterine rupture may be higher in a future TERLAC. But we'll see if there is any data on the risk of accreta in the future. What about some people advocate closing the uterus by purse string versus, again, continuously, by sutures? And what about if you put two layers instead of one? So in terms of sutures, we did recently a meta-analysis looking at different sutures, again, published in the Pink Journal by one of our then residents, now maternal fetal medicine fellows, Kavita Kanuja. And basically, we looked at short-term outcomes, and we didn't find too much differences in terms of multifilament and barb sutures. Barb sutures are quicker by a couple of minutes. In terms of multifilament versus monofilament, not too much change really if you look at the data. Again, monofilament, there's increased scar thickness. Would that be associated with less placenta accreta? We don't know. And basically, this randomized trial did not have long-term follow-up. We're going to ask all of the studies, see if they have or can get long-term follow-up, because this kind of studies will be the best studies to see about the risk of accreta, because they're randomized kind of similar women to different sutures, and they will be good to know. But as of now, really, we don't know, as far as I can tell, from level 1 data, which one is the best suture. We can make hypothesis that some are more inflammatory than others. We can look at retrospective data. But as far as I know, from the randomized trials, there's not enough long-term follow-up to look at the next pregnancy. In terms of including the decidua or not, again, some people feel very strongly about this, one way or the other. I certainly don't know the answer. I did find, early search a randomized trial that, randomized to including the decidua or not in the first C-section, and then following in the next pregnancy, did not find an accreta a difference in risk. But some investigators have found in retrospective studies an increase in niche formation, not an accreta, meaning they didn't report an accreta, but in niche formation, which is short-term outcome. Some people have postulated and shown that including the decidua may end up in more niches. So we really don't know. I think this is one of the biggest controversy. My father was an obstetrician. He told me never include the decidua, and this is 40 years ago now, 50 years ago. I think, unfortunately, a few decades later, we still don't know, but I think it's a question that we're getting closer to answering, and I hope we get more data on this. What about closing continuously the uterus versus putting, one stitch at a time, interrupted sutures? This particular retrospective study showed more acretas with continuous sutures. Again, some people make the case that the more suture is present in the uterus, the more maybe the embryo wants to kind of implant there, and therefore more acretas, but certainly not definite data. There's some data also from this author that there may be more accreta if you lock. Again, the idea here is more ischemia, more inflammation, perhaps, less chance for the uterus to kind of go back to normal and not attract the early embryo, not form a big scar, a big nidus for the embryo to want to implant. Very interesting, very interesting studies, and you can hypothesize whatever you want, but I'm just showing you, as I told you I would, kind of the science, what the papers have shown. These are more papers, some also published in the Pink Journal recently, mostly from randomized trials. Not really much data on accreta after closing the uterus with a per string closure. But one of these papers reported, actually all three of these papers reported fewer niches. And again, these are somewhat recent randomized trials. Hopefully, if we follow these women long enough, they'll get pregnant again, and then we'll know if a per string suture would be beneficial or not in terms of accreta in a future pregnancy. I don't do a per string closure, but certainly I have seen more and more data, including randomized studies, proposing it. And the last thing in terms of uterine closure is, do you do one or two layers? And these two studies, one a randomized trials that had a little bit of a follow-up, and another one a retrospective study looking at the subsequent pregnancy, did not find a difference. And in a way, it makes sense to me. I think that the most important thing is the first layer. If you imbricate above, you're not really including the inside of the uterus. But again, this is very limited data and limited number of patients. I don't think we know yet. And I think one of the biggest messages I want to give is that I hope there are no strong feelings one way or the other on these techniques, because again, the data is limited, so it's hard to have any strong feelings. We don't know yet. The take-home points here are, again, that I think the key to prevent cesarean scarectopic and placenta accreta spectrum disorders is not going to be to decrease C-section, like I said in the first pregnancy. I think C-sections save babies and sometimes save moms and are here to stay. I don't know what the exact percent is. It may vary, obviously, in different hospitals and different patients. But I do think that C-sections will continue to be above 20%, and there will be plenty of C-sections. So the question is, how do you minimize the future risk? Obviously, if you're going to have one or two babies, that will prevent the risk of having more than 3 sections and therefore a much higher risk of previous accreta. But I hope the systematic review that we're doing, looking at all this, I think there are about 18 different risk factors for a possible accreta from the C-section, when you do the C-section, how you do it, will shed some more light as we're beginning to see some early data. And I hope you can help us, not only with the systematic review, but looking at your own data, the data you're looking at in the literature, and looking at the next pregnancy. Because again, for a lot of these techniques, we know kind of the impact on the current pregnancy. Again, I think it's pretty well proven that you should take the placenta out spontaneously and not manually remove it. But what's the risk for a future accreta from manual placenta removal versus spontaneous placenta removal. We don't know, and we need to know. And there are over a dozen randomized studies on that. We need the follow-up from those studies and see what happens in the next pregnancy. I think it's fascinating. I think, I hope I changed your lens a little bit. I made your glasses or your lenses or your view to look at the world a little bit different. I think it's really important, as you can see, our scrubs, it's really important to take care of placenta accretas when they happen and take care of them well and take care of a cesarean scar ectopic well. We have a couple we're following now, both wanting to continue the pregnancy, really risky and difficult pregnancy to manage. But I beg you, the future, I think, is going to try to prevent them to happen in the first place. I know it's important to diagnose them well, to manage them well, but let's try to prevent them as well. And I think from early data, how we do the first C-section or the second C-section, it's important, and those techniques may actually help us decrease, future risks. And thank you very much for your attention once again. I look forward to questions, and I thank again Dr. Ilan Timurtish, good friend, for inviting me. It has been a pleasure, and thank you to Isuog, obviously, for helping to sponsor this great conference. Thanks, everyone.